Welcome to Insights into Advances in Nonvalvular Atrial Fibrillation, an online microlearning library. This is microlearning module number 1, exploring undiagnosed nonvalvular atrial fibrillation and its comorbidities. Well, my name is Christian Ruff. I'm Director of General Cardiology at Brigham and Women's Hospital and Associate Professor of Medicine at Harvard Medical School.
Hi, my name is Jennifer Walker. I'm a nurse practitioner at the University of North Carolina. I work in the Department of Cardiac Electrophysiology.
So let's review our learning objectives for today. After engaging in this educational activity, learners will demonstrate improved knowledge and ability to summarize prevalence and burden of undiagnosed nonvalvular atrial fibrillation. Let's move to recognizing risk and clinical suspicion.
Hello, it's great to see you today. What brings you in today?
I came to check on my blood pressure. I've noticed it's been high lately, and I've been feeling more tired during the day. I know I've put on a lot of weight since the pandemic, but I just have not had any energy to do anything.
I do see your blood pressure is high today. It's 150/90. What numbers have you been getting on your home machine?
Yesterday, my blood pressure was 159/86, and the day before that, 152/90.
Has anything else changed recently? Have you been under stress? Have you been traveling or ill?
Yes, there's been quite a bit of personal stress. I've started drinking wine at night to ease my mind. It usually takes about 2 glasses.
I'm sorry to hear that. Stress and increased alcohol intake can certainly increase your blood pressure. We'll make some changes to get your blood pressure under control. Over time, high blood pressure causes negative changes in the heart, such as thickened heart muscle or dilated heart chambers, which can lead to other problems such as atrial fibrillation or AFib. AFib is the most common irregular heart rhythm in the world. In addition to high blood pressure, you do have additional risk factors for AFib, like increased alcohol consumption, being overweight, and diabetes.
I've heard of AFib before. I think my mother had it. Does that increase my risk for AFib?
Yes, there actually can be a hereditary component to AFib, and age and family history are also other risk factors that we cannot control. However, there are things that we can control. The most recent AFib guidelines recommend controlling a range of risk factors for AFib, such as weight, physical activity, alcohol consumption, smoking, diabetes, and hypertension to reduce the risk of AFib onset, as well as improve AFib after diagnosis. It's important to know that early diagnosis and treatment of AFib can reduce the risk of cardiovascular events, such as stroke.
Atrial fibrillation is really a global pandemic throughout the world. We know that approximately 1 out of every 3 people will develop atrial fibrillation in their lifetime. So many of us will develop atrial fibrillation, or certainly one of our family or friends. The estimated U.S. prevalence is expected to be close to 12.1 million patients in 2030, and the estimated global prevalence, which is currently about 50 million, is going to exceed 66 million by 2050. We know that atrial fibrillation really occurs in concert with other diseases. And this leads to a disease burden that affects many things beyond stroke. First of all, we know there's significant increased risk of mortality, in addition to the increased risk of stroke, which are some of the most devastating strokes we see in clinical practice. Causes heart failure, which is another common condition in our patients, can cause cognitive decline and vascular dementia. This is really of primary concern in many of our elderly patients. It can cause depression. It impairs quality of life, and importantly, it leads to frequent hospitalizations, which is also something that's very important in our care of patients and obviously in our healthcare systems. We know that atrial fibrillation, predominantly a disease of the elderly, is caused by many different things. not only genetics, but many common risk factors like hypertension, diabetes, chronic kidney disease, and other common cardiometabolic conditions such as heart failure, coronary disease, hyperlipidemia, alcohol consumption, obesity is a huge driver. There are many different factors that all coalesce to increase our risk. And this is going to be important when we think about preventing and screening for atrial fibrillation. And importantly, traditionally we focused on once we diagnose atrial fibrillation, we treat with a blood thinner to reduce the risk of stroke. We worry about the rate and rhythm control, but actually the guidelines have really moved to the importance of risk factor management. And that's really a critical pillar in our management of patients. And we want to optimally treat these risk factors for a variety of reasons. One, it can prevent the development of atrial fibrillation. And then when patients develop atrial fibrillation, it decreases their burden of atrial fibrillation. And most importantly, it improves not only outcomes related to atrial fibrillation, but obviously many of the other cardiovascular conditions. And in fact, in the most current recent US guidelines, they have a class 1 indication for lifestyle risk factor modification. What are some of the common guides that we can use? First of all, maintaining ideal weight or losing weight if overweight or obese. And we know obesity is a huge driver of atrial fibrillation and poor outcomes with atrial fibrillation. Poor smoking cessation, very important. Limiting or moderating alcohol use, which is another important modifiable risk factor. Being active physically, and of course, controlling diabetes and hypertension, which are common medical comorbidities in our patients, and really making sure they're on guideline-directed medical therapy. And so let's transition to what steps we can take to diagnose nonvalvular atrial fibrillation.
What does AFib feel like?
Symptoms of AFib can range from undetectable to mild to severe. Common symptoms of AFib are fatigue, shortness of breath, palpitations or irregular heartbeats, and weakness. More severe symptoms can include syncope or passing out. Many patients are unaware of having AFib. It's estimated that about 10 to 20% of people with AFib are undiagnosed. AFib diagnosis can be challenging because people may attribute their symptoms to other reasons, like being out of shape. Also, the symptoms are common in other conditions people with AFib may have, like heart failure. The episodes may be intermittent, making it difficult to catch an arrhythmia for diagnosis. Unfortunately, sometimes stroke is the first presentation of AFib. Are you experiencing any of these symptoms that I've mentioned?
Yes, I have been really tired lately. I do feel irregular heartbeats when I'm running around or when I'm lying down at nighttime. I thought my fatigue was normal because I'm getting older. If AFib can cause strokes, why isn't everyone routinely screened for AFib?
That's a great question. Current U.S. guidelines don't recommend for or against systematic AFib screening, such as screening all people in a certain age group. They note that there's not enough evidence showing that systematic AFib screening does a better job than current practice at reducing bad outcomes associated with AFib, like stroke. However, current guidelines do recommend that healthcare providers monitor their patients at high risk for developing AFib and assess for AFib when they think it's appropriate. Because you do have multiple risk factors for AFib, such as hypertension, obesity, diabetes, the alcohol consumption, and your family history, as well as symptoms of fatigue and irregular heartbeats, I would consider you at high risk for AFib. I recommend getting a 12-lead EKG today to check your heart rhythm. If the EKG shows normal rhythm, I recommend placing a heart monitor for 2 weeks to screen for AFib, which allows for longer-term monitoring of the heart rhythm.
Well, we know that atrial fibrillation, there's variable presentation, and that significantly impacts the timing of our diagnosis of atrial fibrillation. And so early diagnosis really facilitates early initiation of stroke prevention to reduce the risk of AF-related complications, mainly stroke. But many patients remain asymptomatic, and atrial fibrillation is frequently undiagnosed. And one thing that I think many people don't realize is that your risk of stroke, which on average is about 5-fold that if you don't have atrial fibrillation, is the same regardless if you have symptoms or not. Currently, data show that the majority, in fact, 50 to 87% of patients are initially asymptomatic. Eventually many patients develop symptoms, and overall about 10 to 40% remain asymptomatic. But the majority, in fact, the vast majority, are asymptomatic when they initially develop atrial fibrillation. Let's review our approaches to atrial fibrillation screening. And there are a variety of approaches, and there's different pros and cons to both. Let's talk about opportunistic screening. And that really means you check someone's pulse, their ECG, in people who are actually presenting to a healthcare provider. So it's using the opportunity in patients who are coming to see you in clinic potentially or in the hospital to look for atrial fibrillation. Now, of course, that greatly depends on how much that patient or population is utilizing the healthcare system. So if they're not interacting with healthcare providers, then their opportunity for opportunistic screening will be much less. To be honest, there's varying degrees of sensitivity and specificity if you just look at an unselected population. So we're probably going to want to target patients a little bit better. Take the opposite approach for systematic screening. And that's saying everybody who fits a certain demographic, they're getting screened, regardless of whether they were going to see a healthcare provider or not. An example would be you're going to get an EKG in everybody above a certain age. And generally, the guidelines don't universally support this sort of broad-based screening. And then, in this era of precision medicine, really, we're kind of gravitating more to this risk factor guided screening. And that really is using a combination of opportunistic screening, when are we going to see that patient, but then targeting the screening, not just to when we're seeing them, but do they have the risk factors for atrial fibrillation to make it a sort of more of a high yield screening effort. And that's honestly what we're really already doing, at least in cardiology clinics, at least in my clinic. And what's the current recommendations? And they're really where there's emerging guidance about this. There's no universal consensus. It really depends on which guideline you read. The Canadian Cardiovascular Society and their guidelines, they recommend opportunistic screening in everyone 65 years or older. Obviously, more intensive screening in patients who've had a stroke of an undetermined etiology or in patients who have an implantable device. The World Heart Federation also recommends opportunistic screening in 65 years and above. The European guidelines really probably have the most nuanced approach, opportunistic screening again in 65 years or older, but actually systematic screening if you're 75 years or older at high risk of stroke. So saying, if you're at high risk for developing atrial fibrillation, having complication, we should be screening for atrial fibrillation in those patients. I think we've taken a more cautious approach generally in the United States. That's really informed by the United States Preventative Task Force, saying that at this time there's really insufficient evidence to weigh sort of conclusively about atrial fibrillation. The current U.S. atrial fibrillation guidelines sort of used that Preventative Task Force guidance to say it's not clearly established to screen. There's certainly benefits to doing so, but probably most important to realize that atrial fibrillation is really a spectrum and that we really have to monitor patients for risk factors in the development of atrial fibrillation, and it's not just a one-time assessment. And that really means that there are different strategies depending on where that individual or patient is in their arc of their medical journey. Certainly patients who are at risk for atrial fibrillation, who just have presence of risk factors, we may not screen them. But as they're developing that pre-atrial fibrillation, like we think about pre-diabetes, they have structural or electrical changes that maybe are precursor to atrial fibrillation, we should have heightened surveillance, maybe be more active about screening for those patients. Certainly once they developed atrial fibrillation, we're much more intensive. We're monitoring them frequently. We're acting based on those monitoring. We're trying to, rate control, rhythm control. We're potentially intervening to limit the burden of atrial fibrillation. So let's talk about the screening and diagnosis and considering the consequences of what we do.
The EKG today shows your heart rhythm is normal. Because the EKG shows that your heart rhythm is normal today, I recommend placing a heart monitor on for 2 weeks so that we can see what your heart rhythm is over a longer period of time.
I'm not sure I need to wear a heart monitor. I'm not comfortable with devices, wires, and technology. Plus, it'll be hard to get around and do my daily activities with a monitor on my chest.
Heart monitors are now very convenient and simple to use. There are a few different types of monitors, including patch-type monitors that are similar to a large bandage that is applied to your chest. These are wireless and very convenient. You can shower with them and perform your regular daily activities. You do not need to have technology skills to wear the monitor successfully. I am happy to show you the device that we use.
Do you really think we need to do a monitor to check for AFib? Why can't I just start on treatment for it?
Yes, I do think it is important to accurately diagnose the AFib with an EKG recording or a heart monitor. If untreated, AFib can cause heart failure or stroke. AFib is responsible for up to 30% of all ischemic strokes and accounts for over 454,000 hospitalizations in the U.S. each year. Most of these hospitalizations and strokes can be prevented with an early diagnosis of AFib and early treatment. However, some treatments are associated with risks which are reasonable to take if you have AFib, but not if you don't. For example, blood thinners prevent clotting, but also carry risks of bleeding. Also, a monitor will help determine if AFib is indeed the cause of your symptoms. Ultimately, we want to help you feel better and prevent problems.
Okay, I'll wear the heart monitor. It sounds straightforward to wear. I'd like to do everything I can to avoid a stroke.
What best describes the estimated proportion of people with atrial fibrillation who have not received a diagnosis for this disease? Is it A, less than or equal to 5%, B, 6 to 10%, C, 11 to 25%, or D, greater than 25%? What estimated proportion of people with undiagnosed atrial fibrillation meet criteria for oral anticoagulation therapy to reduce stroke? Is it A, 0%, B, 30%, C, 60%, or D, greater than 90%? Please vote. So why screen for atrial fibrillation? And the real answer is we want to reduce the burden of undiagnosed atrial fibrillation. And as you remember, there's a substantial number of people who have undiagnosed atrial fibrillation. In fact, 11 to 23% of non-valvular atrial fibrillation cases in the United States, which is really greater than 500,000, are undiagnosed. And remember, that term non-valvular atrial fibrillation, it really only excludes a very small percentage of patients with valvular heart disease, those with mitral stenosis, rheumatic mitral stenosis, or a mechanical heart valve. Everybody else is really included in non-valvular atrial fibrillation. So that's a huge proportion of patients, almost a quarter. And more than 90% of those with undiagnosed atrial fibrillation are actually at risk for stroke and have a guideline, class 1 guideline indication for anticoagulation. And so there's a lot of them out there, and most of them should be on an anticoagulant to reduce their risk of stroke. And really our goal is to prevent preventable strokes. And we know from a very large Swedish healthcare registry of people who presented with an ischemic stroke, about a third of patients had previously known or newly diagnosed atrial fibrillation. So we're failing in our mission to protect these patients from the devastating consequences of stroke. And only 16% of those had received an anticoagulant in the past 6 months, so a real missed opportunity. And obviously that's the most important part, patient outcomes, preventing, disabling, or potentially fatal strokes. But of course, there's an enormous societal and economic impact to undiagnosed atrial fibrillation. We know the incremental cost of undiagnosed atrial fibrillation is substantial, between $2 to $6 billion, and that's an old estimate from approximately a decade ago now. And much of that cost is avoidable. And in fact, if we increased our use of anticoagulation by diagnosing atrial fibrillation, we would substantially bring down that cost. And so one of the things that I've learned for atrial fibrillation with respect to asymptomatic atrial fibrillation is the more you monitor for atrial fibrillation, the more you detect. So you could screen periodically with an ECG, you could use patch monitors, you could use implantable loop recorders, obviously patients who have pacemakers or defibrillators, but the more you monitor, you'll go from picking up maybe 1 to 3%, and if you have some longer-term implantable monitor, potentially a third of patients you may pick up atrial fibrillation after monitoring for a year or longer. And so the more intensively you monitor, the more you're likely to find in high-risk patients. And so let's review our post-test questions. What best describes the estimated proportion of people with atrial fibrillation who have not received a diagnosis for this disease? Is it A, less than or equal to 5%, B, 6 to 10%, C, 11 to 25%, or D, greater than 25%? And the correct answer is C, 11 to 25%, which is really substantial. That means there's up to a quarter of patients, based on recent cohort data from the United States, that have undiagnosed atrial fibrillation. So it's a really substantial number of patients that we're missing who have risk factors for atrial fibrillation. They do, in fact, atrial fibrillation, but we haven't monitored them, so we don't know. What estimated proportion of people with undiagnosed atrial fibrillation meet criteria for oral anticoagulation therapy to reduce stroke? Is it A, 0%, B, 30%, C, 60%, or D, greater than 90%? Please vote. Well, the answer is actually D, greater than 90%. We know that undiagnosed atrial fibrillation is common, and alarmingly, the vast majority, in fact, greater than 90% of patients with undiagnosed atrial fibrillation actually meet guideline criteria for anticoagulation to reduce stroke. So that's why it's so important to identify these patients, because the majority, in fact, almost all of them, will actually qualify for anticoagulant therapy. So in summary, atrial fibrillation is common. 1 out of every 3 people will develop atrial fibrillation in their lifetime. Why is that important? Because it's associated with poor outcomes. We all know about the 5-fold risk of stroke, but it's also associated with a significant excess risk of mortality, dementia, and impaired quality of life. Importantly, many patients with atrial fibrillation remain undiagnosed and therefore do not receive treatment, whether that's anticoagulation, rhythm control management, or lifestyle changes that are important, because we know, and it's been proven in clinical trials, that modifying those risk factors can improve outcomes as well as their quality of life.